This section I will be discussing about molecular classification of endometrial cancer. Traditionally, endometrial cancer was divided into type 1 and type 2 classification based on histopathological findings. But this has its own limitation in capturing the complexity of these neoplasms. So now there is a new classification which incorporates molecular features also. This offers more consistent categorization and provides predictive and prognostic information based on the molecular subtype of the tumor. There are four molecular subtypes which have been identified, and this testing is performed on standard pathological samples. The four types are pole mutated, MSI, NSMP, P53 abnormal. I will be discussing every one. So all different types of endometrial cancers, endometrioid, endometrial grade 1, grade 2, grade 3, clear cell, serous cell, have different varieties of molecular features according to the different types. You can see the thick line and the thin line. Thick line denotes the more association of particular cancer with particular molecular feature. So coming to pole mutation, it is a type of mutation which is characterized by recurrent mutations in the exonuclease domain of the pole gene involved in DNA replication and repair. Patients with these mutations tend to be younger, thinner, and despite seemingly aggressive pathological features, they have highly favorable outcomes with over 96% 5-year survival rates. Adjuvant therapy in these patients has not shown any improved survival outcomes, so it is not beneficial, and we can de-escalate the adjuvant therapy in these patients, although they may be at a higher stage compared to the patient without pole mutation. Immunotherapy may be an option in recurrent pole mutated feces due to high presence of KILs. The second type, mismatch repair deficient type. In this, it is characterized by dysfunctional mismatch repair proteins, resulting in low levels of somatic copy number, alteration, and high mutational burden. Patients with these type of tumors have high levels of TILs, that is tumor infiltrating lymphocytes. This molecular subtype is associated with a high tumor mutation frequency, exceeding 10 mutations per megabase. Another type is no specific molecular type. So this is characterized by genomic stability, proficient mismatch repair, and moderate mutational load. These patients exhibit normal P53 mutation and are not associated with pole mutation. This consists of endometrial neoplasms that show estrogen and progesterone receptor positivity and high response rates to hormonal therapy. And the fourth type is P53 normal. So this is characterized by high somatic copy number alterations and mutational profiles. This is associated with a poor prognosis responsible for a significant proportion, 50 to 70% of endometrial cancer mortality. Approximately 20 to 25% of these patients show HER2 and HRD based on a RAD51 foci formation. And anti-angiogenic agents may have value in the treatment of an advanced or recurrent P53 abnormal PC, either alone or in combination with other therapies. This P50 abnormal is most commonly observed in serous carcinomas, 93% of serous carcinomas, carcinosarcoma, and clear cell sarcoma, and grade 3 type 2 endometrial cancers. But it has a very lower prevalence in grade 1 or grade 2 type cancers. Chemotherapy combined with radiation therapy has shown superior outcomes compared to radiation alone in P53 PCs based on data from PROTECT-3 trial. So in conclusion, breast cancer susceptibility genes, BRCA1 mutation carriers, particularly BRCA1A mutation carriers, have an increased risk of developing P53 endometrial cancers. 2020 guidelines incorporate molecular features in the risk assessment and treatment decision making for endometrial cancers. These guidelines classify all early stage 1 stage 2 pole mutated feces as low risk, recommending no adjuvant therapy. On the other hand, stage 1A P53 abnormal feces with any myometrial invasion are classified as high risk and are recommended to receive chemotherapy with or without radiation. Thanks.